All right. Today we have Dr. Thomas Hallinan. You have a PhD in psychology. You've been working here for about 6 years at Atlas Psychiatry. And I'd like you to tell me a little bit about yourself and your background. And then today we're going to talk about cognitive behavioral therapy and how it's different from psychodynamic therapy. You practice both, but you lean heavily towards psychodynamic therapy. So thank you for taking the time out of your day to talk to me.
Oh, my pleasure. Thank you for having me.
Sure.
I'll start with maybe what got me into psychology and psychotherapy to begin with. I was maybe 11, 12, and I was walking around the library, and I remember finding this illustrated guide to Freud, which is sort of like a comic book about a particular thinker's life. And I knew a little bit about Freud just even as a kid. I remember opening this book, and it was one of the most fascinating things I'd ever read before. And since then, I've always been very, very interested in psychoanalysis and psychology. In undergrad, kind of figured I was going to go the PhD route, and so started doing the things that you kind of need to do to get in that direction. Picked my graduate school because it had a heavy emphasis on psychoanalysis and philosophy. And I've been fortunate that I kind of, I think unique in this, but realized what I wanted to do when I was pretty young, knew exactly what I needed to do to get there. And then when I arrived, it was pretty close to what I thought it would be. And I've been very, very satisfied with it and really glad I picked this route, which I know not how it often goes for people when they pick their profession. But I still find myself very, very fascinated with this material and in general with just people.
And how did you end up, well, during your training, how did you determine what type of psychologist you wanted to be, or what kind of modalities you wanted to use in your therapy?
So in undergrad, I knew I wanted to go to a program that was going to lean psychoanalytic, psychodynamic, and I'll explain a little bit about what that means. But the program that I went to was extremely psychodynamic, to the point that they offered a class for CBT, cognitive behavioral therapy. It was in the course catalog. The 4 years I was taking classes, it was never offered. So one of the things I did do, because I felt like because CBT really wasn't represented, I think we strawmanned it a lot in grad school. And so I wanted to learn more about it. So in grad school, I did my practica experiences at the VA hospital in Pittsburgh, worked with a CBT specialist and learned at the beginning some basic principles of the therapy and the theory. Then I did my internship and my postdoc at the VA here in New Orleans, because I did also want to continue to develop my skills in behavioral psychotherapy too. So I feel that I did have these kind of two tracks. I still tend to think about people in general psychodynamically, but I do feel like I'm happy that I got the experience with behavioral therapies, because I feel like my repertoire is much wider.
So if somebody were to come to see you to do psychodynamic psychotherapy, can you explain the difference between psychodynamic versus cognitive behavioral therapy? We do both here at our office or at our practice, as you know, but I don't think patients understand sometimes why we might send them to you versus to the other one.
I try to tailor what I'm doing with somebody to the person specifically. I usually need a couple visits with somebody to get a good sense of what I think would be most helpful. And then usually I'll then offer sort of like, hey, I think that this would be a good fit, and here's why, but this is another option that we could take, and this is why it could be helpful, but these are the reasons why I think this would be a better fit for you. And that's based both on the diagnosis, like what the person says their goals are, and then like a little bit about their personality and like what are they willing to do in therapy. So broadly, psychodynamic psychotherapy is taking lessons from psychoanalysis and the theory of psychoanalysis, but applying them in a very different method, in a more traditional, once a week therapy that is face-to-face. And the method in psychoanalysis is very distinct, and it requires a lot more from the patient than some people are willing to give, multiple meetings a week, those kinds of things.
So multiple, like 50-minute sessions a week, maybe 3 or 4 per week for many months, right?
Right, potentially years.
Okay.
And some people are really interested in that kind of like very, very deep work. But a
Mhm.
lot of people either, structurally can't make that kind of commitment, or they're not necessarily interested in doing something of that depth. So
Mhm.
psychodynamic psychotherapy had developed based on the theories of psychoanalysis. And psychoanalysis, we all know, is connected to Freud, but it was 100 years
Mhm.
ago when he first published, over 100 years ago, Interpretation of Dreams, and things have evolved over that 100 years. But it's based on Freudian ideas that I think a lot of people are familiar with, just because a lot of his ideas have trickled down into our mainstream culture. I mean, when we say
Right.
you're defensive, that's Freudian.
Right.
When we
Yeah.
say you have like a Napoleon complex, like that's Freudian.
Yeah.
And a lot of the ideas of psychoanalysis are just like accepted in our culture, but not necessarily known as like psychoanalytic ideas.
So it's interesting that you point that out, because folks that see you, you could employ that that knowledge of how our psychology works,
Mm-hmm.
but they already have some terminology
Mm-hmm.
you might be using. So
Yeah, a
you,
lot of what we call
yeah,
psychobabble is just
yeah.
using some psychoanalytic terms.
So then psychodynamic therapy, we know that it's not as frequent per session, or the frequency is less. So it's probably once a week. In that once a week time, like you mentioned, you want to know the diagnosis, the patient's goals, what their personality is, um, and uh, and then why would you pick psychodynamic therapy for them versus going the CBT route? And tell us a little bit about that.
So I think some of the more salient differences between the two, CBT was developed by an American psychiatrist who was trained in the Freudian style psychoanalysis, and for a variety of reasons had become frustrated with it. And so he developed this theory that then has been heavily researched since he developed it, which is very, very different in its technique. It's different theoretically, looks very different, and I'll explain kind of what that looks like concretely. But psychodynamic psychotherapy, I think, differs significantly in that it emphasizes affect, emotion over thought,
Okay.
cognition. It is, I think, much more attuned to and focused on the relationship between the therapist and the patient as a mechanism of action in the therapy itself.
Mm-hmm.
Of course, the idea of this unconscious is central to psychodynamic psychotherapy, which is the idea that I think everybody is familiar with on some level, that and I think that this is very clear when we all recognize we do things that are not in our best interest over and over again sometimes, and don't really understand why, but
Yes.
still do it and still participate in it. And I think of that as sort of like what we're getting at with the unconscious, that something's happening that consciously is not necessarily a good thing, yet we feel compelled to continue this pattern. We also know from neuroscience too that like a lot of what is happening in the brain is not accessible to consciousness, right? There's a ton going on that we can't consciously see happening. And that means, like, reasonably, a lot of our psychology is not fully accessible to us. And CBT acknowledges this too, right? Like, it has the idea of these core beliefs, these core schemas,
Right.
that we can't directly access, but they do influence our consciousness. And so that idea is shared there. I think what I like about psychodynamic therapy too is that psychoanalysis has always been much more in dialogue with philosophy.
Okay.
I think particularly in psychotherapy, philosophy is interested in a lot of the same questions that a patient would be interested in, like, how do I live the good life?
Yeah.
What does death mean? What does it mean to be a finite being?
Yeah.
How am I supposed to know who I am? Is there a God? Like, what does it mean to be a good person? I mean, these are all philosophical questions, essentially. And I think that psychodynamic psychotherapy and psychoanalysis really benefit from a theoretical connection to philosophy and sort of an engagement with it and a conversation with it. Not to say that CBT doesn't, but I don't think it's as explicitly interested in philosophy as analysis is.
So in psychodynamic psychotherapy, you're trying to help patients uncover some of their unconsciousness to know why they do what they do. Like their inner machinations, or I don't know if that's the right word for that, but just how they work.
Mm-hmm.
And you said that it focuses a bit more over or on emotion and affect over thought. So can you describe when you're sitting with the patient, what do you mean by that?
Maybe using an example from CBT is a little bit might illustrate this difference better. So CBT is much more focused on thinking,
Mm-hmm.
and it theoretically sees this really clear connection between the way that the things happen, the world exists, and because of the nature of being human, everything we experience about reality is an interpretation of some sort.
Yeah.
And CBT is looking at the ways in which pre-existing beliefs about who I am, what I am, about the world, about other people may have become distorted at some point and now are producing regular distorted thinking that makes people feel anxious or makes people feel depressed. And I think an example with anxiety would be somebody who tends to overestimate the chances of something negative happening.
Right.
That they worry that if they step out the door, something bad is definitely going to happen, which is a pretty distorted belief, because I step outside of my door almost every day, and very, very rarely does anything really truly bad happen, right? So for most people, that's a slim chance.
Mm-hmm.
And the distortion in that may have been caused by something in the past, leading them to believe that the world is less safe than it is.
Yeah.
Potentially experiences with caregivers or experiences in childhood that led them to believe, like, I have to be careful all the time or something bad will happen.
Mm-hmm.
And the technique of CBT is to sort of tease out these patterns of thought, recognize them as cognitive distortions. They've been distorted in a very particular way, and there's patterns of thought in that.
Yeah.
And helping the patient recognize when they are distorting reality, and sort of teaching them a method to check that and replace that distorted thinking with more adaptive thinking or more truthful thinking or more healthy thinking.
And so when you mentioned affect or emotion, well, affect being what somebody is showing on their face and their body, I guess they're nonverbal, conveying an underlying emotion. You said that you might focus on that a bit more in the psychodynamic work. Is that true?
Yeah, because with CBT, the thing that you are working with is thoughts.
Yeah, right.
And you're really, you are seeing this connection between the way you think affects the way you feel.
Yeah.
Now, most of us don't experience it necessarily in that order, right? Like, we might feel something before we even realize what we're thinking.
Exactly. Yeah.
But CBT, in order to, the way that the method works is that we just have much more access to our conscious thoughts, right? Like, we may not even understand why we're feeling a certain way, but we can tell you what was going through your mind, in this moment. And so the attention to the patterns of thought and using homework, which is another big difference between CBT and psychodynamic psychotherapy. CBT is very heavily focused on homework and a lot of assignments in between sessions.
Yeah.
A lot of writing, a lot of thinking about thinking, a lot of documenting, a lot of tracking.
Yeah.
And while sometimes that does happen in psychodynamic psychotherapy too, it is sort of core to CBT. If you're not doing the homework, you're not really doing CBT.
Right.
So that is one of the things that I will assess with somebody, because a lot of people, even if they know it will help them feel better, are just not going to do the homework.
So say a patient tried CBT and thought it was too tedious to do the homework. Maybe they know their core beliefs and they just didn't take to that type of modality. How would psychodynamic approach someone with anxiety or depression who didn't do well in CBT?
I think that in some ways we're trying to achieve the same thing with slightly different methods and then slightly different theoretical understandings of what's happening. But I think that similar to CBT, one of the things you're doing in psychodynamic psychotherapy is looking at defenses that the patient has acquired over time.
What are the defenses? Can you list some of the defenses that people might use?
Yeah, so an example that I often use when I'm sort of explaining this idea to a patient is, and this is just one of my go-tos, all of us have to survive childhood. And even if we live in a household where there's not necessarily extreme neglect or abuse or material deprivation,
mm-hmm.
you can still live in a house, and most of us do, where there are conflicts, there are problems, there are issues. And even if we're not facing, horrific trauma, it's still hard growing up.
Yeah.
And all of us, our objective as a kid is to survive to adulthood, right? And if survival is the goal, then anything's on the table, right? Anything that could get you to that is okay.
Yeah.
So a lot of the things that we have to do as kids to sort of deal with a reality where we don't have a lot of say in it, we don't have a lot of agency or control over what's happening to us, is that we have to defend against things that we might not be able to handle as a kid.
Okay.
The problem in this, from psychodynamic psychotherapy's perspective, is that sometimes those adaptations that were really helpful as a kid, right? Like they got you through a terrible situation, or they helped you survive, an abusive relationship with a parent,
Yeah.
are really problematic as an adult. They served a role once in your life, but it is something that sometimes is hard for people to recognize, being connected to that, and it's hard for them to give it up because it's something that as a kid kept them safe.
Right.
So,
Okay.
and I think a good example of that would be a kid that grows up in a household where, one or both of his caregivers, his parents, are deficient in some significant way. And for a kid, our parents are our gods, right? And so for us as a child to reckon with, something's wrong with my mom, something's wrong with my dad, like they are not a good parent, they're maybe even not a good person. It is like thinking God's bad, right? Or God isn't fully complete and isn't going to take care of me. And that's just a thought most kids cannot tolerate. And so in those situations, something that often happens is the kid starts to blame themselves for the way that the family is functioning, or blame themselves for the way that their parents are treating them. And that does a couple of things.
Yeah.
One, it helps them sort of deal with the terrifying thought that my parents are flawed and they are absolutely in control of me. And that is a terrifying thought. They can avoid that. And two, it gives the kid like a little bit of sense of agency that they don't really have, right? Like if my parents are flawed, there's nothing I can do to help them help me, right? There's nothing I can do to respond to that. But if it's me that's flawed and my parents are treating me like this because I'm flawed, then if I can be better, I can get their love, I can get their attention, they will treat me decently.
Yeah.
And so that is something we would call introjection, which is this idea that you are taking in something from the outside world and sort of like blaming yourself for something that's not your fault. But it's a defense, in this case, against the terrifying thought that like my parents are a mess, like they're in charge of me. And most kids cannot tolerate that thought. What happens then is somebody goes into adulthood and is continuing to use this defense. And so an example might be somebody who it almost like stopped taking score, has done all these good things with their life, maybe is, pretty successful in their job, successful in their relationships, but they still feel like they're lesser than, and they still feel bad, despite all the evidence in their life that like you're doing all right. And that's because that defense is still kicking in, right? Like they're still making things their fault that are not their fault, and making that connection to why this defense formed, why this defense isn't helpful anymore, and creating awareness of when it's sort of kicking in the moment.
So what will an adult think is their fault if they have this introject?
So a person that never thinks they're good enough, despite the fact that like everybody around them thinks they're awesome.
Yeah.
Right. And it's like the external evidence of their goodness, it is like viscerally present, but they just don't see it or they don't believe it.
So how do you help someone work through that and kind of negate that or undo that, if you will?
Well, part of it, I think, is starting to understand why. And so one of the things that I think is a difference between psychodynamic psychotherapy and CBT is very, very present focused.
Okay.
We're interested in like why you developed this way, but more than anything, we're interested in like what happened this week and how did you respond to it. Psychodynamic psychotherapy is a bit more focused on the past and sort of understanding why did this defense come into play?
Yeah.
What are some of the like salient childhood experiences that are connected to this, and how is this stuff continuing to play out in your life now? So making that connection between why this defense formed, why it was potentially useful then, but like why it's showing up now and it's not helping. In fact, it's creating problems.
And so do you think that some of this is unconscious too, that they're just not aware of why they do what they do, why they think the way they think, and they need to go deeper? How would you bring awareness? Is it just from someone talking about something enough, giving them a safe place and space to, go over these past things that they probably haven't thought about for a long time?
So you're listening in a very particular way, and you're constantly thinking about where the pieces of information you're getting from the patient fit, and you're sort of constantly hypothesis testing. Like you have an idea of what's going on with this person, that you're constantly comparing the data of what they're saying in the visit, how they're responding to what you say, how they narrate their own experience. Like, how does that map onto the idea I think I have about this person? So that's like constantly evolving. And then as you get more and more of an understanding of the person you're working with, it's almost like and this is a metaphor from a different therapy, but I think it applies here too. Um, if you think of yourself climbing up a mountain, and this is life, right? Like there's challenges, like you have goals you're trying to reach, you start at a bottom and you're trying to move your way up. But if you really also think from the perspective of the person climbing the mountain, all you really see is the stuff right in front of you, right? I think where therapy can be really helpful, and I'm on my own mountain, I'm living my own life, I'm doing my own thing, but one of the unique parts of therapy is like that's not what we're here for, right? We're not here to talk about what's going on with me, we're here to talk about what's going on with you. But I'm on my own mountain, but because of my perspective, I can see where you're at, and I can see stuff that's coming up that you cannot see. And I can point you in a different direction that right now, just because you're pressed up against the mountain, I could say, whoa, don't go that way. There's an outcrop there. You're not gonna be able to make it go right. And
so you're saying
from a
you're saying
different
that you as a therapist, having worked through these things or having a theoretical understanding, you can help them navigate which way to go. And
yeah, well, everybody is unique, of course.
Right.
There are still patterns that you see over and over again in certain kinds of people. And those patterns reveal like a particular dynamic. As you get more and more clarity about like, where does this person fit? The way that you intervene with them changes too. But in a nutshell, really, you're using the way that they talk and the way that they think about themselves and reflecting back and highlighting certain things to help them see where these conflicts arise in present day and how they're connected to the past. And then suggesting alternative ways of approaching problems, which is, across all therapy, really.
That's
I do think another part that is unique to psychodynamic is the emphasis on the relationship.
Right.
So the relationship in therapy is weird, right? It's not like any other relationship we have in our lives. Because
patients always tell me that they could talk to their friend at a coffee house or something, and why don't I just talk to somebody who's sympathetic? So you're explaining why that in dynamic therapy that doesn't work. Go ahead. Sorry.
Yeah, because in that friendship, it's a two-way street, right? Like they get a chance to talk about what's going on with them. You get a chance to talk about what's going on with you. You're concerned with what's going on in their life. They're concerned with what's going on in your life. Sometimes you lean on them. Sometimes they lean on you.
Yeah.
Therapy is not that, right? Like I don't talk about myself. I don't talk about what's going on with me. Our mission and our project together is what's going on with you. Yeah. And because of that, it's a really odd relationship in that our focus is solely on you. And our project is solely engaging with you. Whereas in any other relationship, it's about both of us, right? And it's about both of what we want from each other, both of our own like housing dynamics, both of like how we kind of connect with each other in the world. And I think because of the uniqueness and that sort of like imbalance in therapy, we can talk about things that are happening in the therapeutic relationship in a way that would like be weird to talk about with friends, right?
Yeah.
I can notice things that are happening in our relationship that probably are happening in other relationships that you have, but because I don't take it personally, because I know it's not about me.
Yeah.
I help you talk about this in a much more objective way without judgment and point out ways in which like other people in your life may experience this too.
So give me an example of that, like where you've experienced something that the patient is doing in the office with you that you could generalize to other relationships.
I think so an example might be if you notice like the patient is like off for whatever reason. And let's just say in this particular example, you know that this is a person who really struggles to assertively express disappointment, anger, when something's happened in a relationship and they're upset about what's happened.
Okay.
And in this visit, you can kind of notice that this person, maybe they're not making eye contact like they used to. They're being very short in the answers they're giving you. Maybe they even like sit on a different part of the couch than they usually do.
Right.
What you can do in this is talk about, you seem upset with me. Can we talk about what's going on?
Because you feel it, and that's the relationship giving rise to a conflict that they're creating in the therapy, and they're kind of projecting this onto you. Yeah.
Yeah, and I think
they're bringing this in. It's not because maybe you did anything in particular wrong, but maybe something in a former session had happened that led up to this moment.
Yeah, and I think that it then we can discuss it in an objective, judgment-free way. Maybe they're upset about something I did or didn't say the last visit, or maybe I said something that reminded them of something their father said, or whatever the issue is. but then we can bring it up and talk about it, and then we could talk about why they didn't want to talk about it with me, right?
So
Like,
then do you tell any patient prior to going on this journey with you, there are going to be times when I need you to tell me things you might not typically tell people about how you feel about me?
Mhm.
And
Yes, yeah.
and so you actually tell them that rather than let that happen organically. You'll kind of coach them that's kind of
It depends on the patient. I think
Yeah.
some people do need it being made explicit, but I think a lot of people understand it intuitively.
Right. So in this case, you say, okay, let's talk about this. I noticed that something's off here. You're not really making eye contact. You highlight that, and then what happens after that?
Well, we talked about maybe whatever it was that I did that upset them. If something needs to be repaired, we'll do that. But then I think we could talk about. So it seems like this probably happens in other relationships. Maybe one of the reasons why you're struggling to get your needs met with people is that you clam up like this when you're mad.
Yeah.
And the way that others might perceive this is you're being aloof, or maybe you don't care, or maybe something else is bothering you, you're anxious. And one of the main issues in your life is that you have trouble being assertive about your needs and what you want, and repairing relationships that have had a breach in them. And we can talk about what's happening in this moment. Like, why didn't you feel comfortable talking about this? In a way that would be weird in another relationship.
Right.
And it's not personal, right? I'm not going to get offended. You can call me names and I'm not going to take it personally.
So let's talk about that. What's it like to work with folks who might be upset with you frequently, or like creating this tension in the relationship? How do you, what is that like for you, and how do you deal with that, I guess?
I think that like sometimes those kinds of breaches can be some of the more valuable sessions. Because often you're also like modeling, like this is the healthier way to maybe like repair a relationship where there's been a misunderstanding or a trespass, whatever.
So you see it as an opportunity to model, to repair, and you welcome the work. This is part of the work.
Yeah, and also like explore like what was happening that you in how you were interpreting what happened that led you to feel this way, and could that be happening in other relationships?
Yeah.
Maybe I was running a little late, and that turned into, you don't value my time, and you don't actually care about me as a patient, and like, you don't think of me as good as your other patients or whatever.
Right.
And being able to talk about that in a way that like you would never really talk about it with your primary care doctor, right?
Right. No.
Or you may struggle to have that conversation with a friend who's like always like picking you up to like take you to an event or whatever. But because this has happened, one, we can talk about like, well, maybe that's not what was going on for me. I was really apologetic, and like, honestly, I lost track of time, and I really apologize, and it was not intentional. But also explore, why do you think that upset you so much, right? Well, because my spouse does this, or my father used to do this, or my mother used to do this, and the way they reacted when I told them I was upset kind of told me I'm not supposed to say this to people. And encouraging a kind of talk and a kind of dialogue that maybe this person hasn't had the chance to have that, or relationships that encourage it in the past.
So patients sometimes tell me when they're in this type of therapy, and this is a different kind of moving on to a different topic, that they might feel like they're just doing the talking and there's nothing happening. But from what, in my own therapy, when I was an early career psychiatrist, I guess, you would know palpably when things shifted in the therapy. Like you could value what you got out of it, even though it's nuanced sometimes. The relationship, it's very interesting. It's like you have this relationship with somebody who's not your friend, and you're working through it. So when patients tell me, well, and I'm not saying these are patients who saw you specifically, but they may be seeing somebody who's psychodynamic, and their complaint is, well, my therapist doesn't talk to me as enough. They don't give me advice and that type of thing. How would you respond to that?
So I think sometimes a therapy kind of stalls and shifts into what we would think of as just more like supportive.
Right.
Sometimes that's because like, maybe at this point in this person's life, like they are not ready for something deeper and something potentially like more like strenuous. But sometimes I think with certain therapists, they say they're doing psychodynamic therapy, but don't actually understand the theory and are really just doing supportive therapy, which is basically come in, you talk about your week, you vent a little bit, and we don't discuss like patterns that are emerging here. We don't talk about what's going on in the relationship. We don't talk about setting goals or like making progress towards those goals. Come in once a week, and I think that that's what people are thinking of when they're concerned that therapy is just like talking to a friend, because that's kind of what a friend does, right? Oh,
Right.
well, that sounds really tough. I'm sorry for you. You know, let me know if I can do anything, or you'll get through this. Like, I know you're tough. You know,
Right.
tell me if you need to.
Right.
All that can be helpful at points. Like, that's not therapy.
So that's where psychodynamic therapy, especially twice a week therapy, really ups the ante or add some fuel to the fire of progress, probably, right? Because then they're seeing you twice a week. There's less things to talk about in between session. Like, they're not just telling you the weather and the news. They're talking about how you made them feel last session and your comments. You can go kind of deeper on.
Yeah, and people, not always fully consciously, but often fully consciously, will be thinking about what was discussed in therapy until the next visit.
Yeah.
And that's always a sign that like stuff's moving, right?
Yeah.
So the homework in psychodynamic psychotherapy isn't as explicit as it is in CBT, and it is something that happens, I think, a little bit more passively. But I've frequently had visits where somebody will come in, they're like, I've been thinking a lot about what we talked about last week.
Yeah.
And like, that's how you know, like, stuff's starting to shift, like stuff's starting to, like, they can't quite get that thought out of their mind. It keeps coming back and they keep asking and being curious about it.
Do you ever feel kind of smothered if you're seeing somebody twice a week or more frequently? Maybe smothered is a bad word, but like where it's too intense for you in the room? I always imagine like to do therapy, because you have to gauge your own feelings in the room, and you're kind of the, what do they say, the antenna for how the other person's doing. So what's your own, I guess, counter transference or transference like?
I mean, I think that, you know, having done my own therapy, I think that is extremely helpful, because one of the things that you're trying to, as you're like sitting with the person and talking, one of the things you're constantly doing is sort of checking your response to the patient. And if you have become aware of and made progress on your own like vulnerabilities and your own dynamics, you can start to easily suss out, okay, that's me, that's not the patient, right? Like this reminds me of my relationship with my father. Don't say anything now, because that's not useful, right? That's for you, that's not for them. Right. So like part of it is having done my own therapy, I think I'm aware of where my dynamics are, and I've been able to sort of like prevent them from leaking into the room often. And then honestly, I think it's like, you know, this, like any job, I mean, you got to make sure that you're taking care of yourself, right? Like, so you know, basic stuff that sounds boring and nobody really likes because it's not sexy, but like making sure I sleep enough, making sure I exercise, making sure that I eat healthy. Like, and I think that allows me to tolerate what can sometimes be really intense emotional visits. But no, I never feel smothered.
Well, I thought maybe like, you know, if someone's coming in 3 or 4 times a week, but mostly you will see folks for 1 or 2 times a week, right? Okay.
Yeah, I think that you know, it's very different in analysis when and we won't have time to talk about that today, and probably Dr. Anson's the better one to talk, being trained as an analyst. But the method is very, very different, where you be coming in multiple times a week. The analyst is much less active than a therapist would be in a psychodynamic psychotherapy.
Okay.
And it looks a lot different. But I've definitely seen people more than once a week doing psychodynamic psychotherapy, and I find it really rewarding, because, you know, if a week goes by, there's always stuff that needs to kind of get talked about in the week, right? But if only a couple of days go by, to your point, not much has happened other than they've been thinking about what you guys are talking about, right? And that stuff is percolating and connections are being made. And one of the things I'm always trying to do is get the patient to be interested in their own experience and like question their own experience. And I think that is something that is really important in psychodynamic psychotherapy. And meeting more regularly, people do start to really think more deeply. And it's sort of like that percolation that's happening. I can't quite let go of this thought that came up in therapy last time. And now I've spent 2 full days thinking about it, and I have a lot I want to talk about. Like, I made this connection between this thing that happened to me when I was a kid, this something that's going on at work and why I'm responding so intensely to that. And then you said 2 weeks ago, connected with this idea of like how my mother treated me when I was a teenager and like my relationships with women. Not everybody can do that, either like financially or practically. And I don't always think it's necessary, but I do think it can be really helpful to like accelerate what's happening in therapy.
And where are you working towards with the patient too? Or I guess a better question would be, what type of growth do you see in patients as they do therapy with you?
It depends. I do always try to meet people where they're at, and sometimes really the only thing a person wants is symptom remission, right? Like I have panic disorder and I don't want to have any more panic attacks, or I have generalized anxiety disorder and I just don't want to be as anxious as I am now. And I think sometimes if the goals narrow in that sense, we're very, very focused on that, right? We're very focused on giving you a GAD assessment where the numbers go down over time. And often I think like a behavioral treatment's more effective for that, because we want to kind of contain it to just what we're working on, which is just the symptoms. Whereas I think a psychodynamic psychotherapy is by nature broader. And I think it's more, well, of course, we also want symptoms to be less painful for the patient.
Yeah.
The larger goal is really more like, personality character change, right? Rather than symptom remission in and of itself. And or like recognizing that maybe the symptoms are just part of being human and aren't necessarily something that you have to like want to do away with.
Yeah.
You come to a different understanding of them.
And do you find that folks who have unconscious material that they haven't expressed before and holding that around, that it causes what they call signal anxiety? Is that is that how you think of it? Meaning like, we'll have some folks with generalized anxiety disorder where they're on the surface of their life and their psychology, they feel anxious, but they often don't know why they feel anxious. And so CBT doesn't help them because they can't tell you that it's more of a free floating anxiety maybe. And from what I understand is like that can be tethered to an emotion that's been deeply either suppressed or repressed. And so, or inner conflict. So
yeah. So Freud actually like described that kind of anxiety specifically as something is trying to come into consciousness that you do not want to think about.
Yeah.
And in contrast to like anxiety that has an object, right? Like I'm going to French Quarter Fest this weekend, but I, was deployed to Iraq, and like any group of people together to me signifies danger because there might be a suicide bomber in there or whatever. Like that's very clear. The patient understands why they're reacting the way that they are. They can its history. Versus some people just don't understand why they're feeling what they're feeling, and often that is something unconscious, right? Because there's this idea in psychotherapy broadly of psychic causation. Like nothing's happening for no reason. Everything's happening for a reason.
Okay.
We haven't quite figured out what the reason is yet.
Very interesting. And so you help them uncover that, and perhaps like you're talking about, to kind of bring it back to the childhood stuff that you're mentioning, where if you have somebody who learned a certain coping defensive skill when they were younger, and for example, what did you mention about thinking their parent is God and their parent isn't God?
Introjection would be, so people are pretty familiar with projection, which is me projecting something that's going on internally to me onto you, right? Like I'm upset with you because you were, late to pick me up, and I'm telling you, why are you so mad at me? Everybody gets projection. So introjection is the opposite, where I'm taking your dynamics and pulling them into me, right?
Yeah, right.
That would be the example that we talked about earlier, where my parents are actually the ones who are flawed, right? My parents were a mess, but as a kid, they were the ones that took care of me. They were the ones that my like existential safety depended on. So thinking that they're messed up, it's terrifying. And so it's easier for them as a child introject this, right? Oh, it's not them. It's me, and I have some power and control in this. Like if I can only be good enough for them to love me, right?
So then, as an adult, then in therapy, psychodynamic therapy, they may uncover, hey, my parents really did have these problems. It's not me, and I don't have to fix them. It's
or they've recognized this, right? Like they are an adult. They recognize their parents were a mess. They can see the connection between their childhood and how they're feeling now. They just don't necessarily see in real time, colleagues are giving you compliments and you doubt them, right? Or your spouse tells you how happy they are with something you did for them, and you doubt them, right? And all the good stuff that's happened in life, like you kind of undermine or you diminish, and you don't understand why you feel bad about yourself all the time.
Yeah.
And that's because of this defense that formed to get you through those experiences as a child with your parents. They're still working right now, but they're not useful anymore, right?
Right.
Because your parents are a mess. Like, you can accept that as an adult, but now this defense is getting in the way of you recognizing the experiential evidence of your life that, like, you're doing really well.
Yeah.
Most of the people in your life think you're awesome. Like,
well, but if they come in and you continue to tell them, like, hey, you are really awesome, isn't it just more of the same? Another person just telling them they're awesome and they still feel the same? Like, how would you unravel that or help them?
So, like, for instance,
resolve the issue. Yeah.
One of the things we can talk about is if I offer like a compliment like that, and we can talk about why they don't believe me.
Oh, okay.
Right, which would be weird to have that conversation with your boss, right?
Right.
Or maybe even weird to have that conversation with your spouse.
Yeah.
And we can examine it in a safe, non-judgmental way that you just can't do in other relationships.
Right. That's fascinating. Well, thank you for your time and doing the deep dive with some psychodynamic. If a patient wanted to come see you, what types of symptoms do you usually see in folks that come see you that you work on together? So
as is true, I think, for most of us, a lot of depression, a lot of anxiety, substance use. My specialty training was in trauma. So my internship included a lot of trauma work at the VA. And I specifically did a postdoctoral fellowship in trauma at the VA as well. So I do have a specialty in trauma. And I typically do often a lot of behavioral therapies for trauma, just because they have a really robust research support.
That's great. Well, Dr. Thomas Hallinan, thank you very much. And let's do this again soon.
Absolutely. Thank you, Dr. Pejic.
Okay, you're welcome.
Have a good weekend.
You too.
Bye.